So good morning, everybody, and happy Friday. Welcome to Friday Chalk Talk. Today, I've got the pleasure of introducing our guest, Amy Pesch, and today's discussion is going to be on prognostication after stroke. Amy's been working in the field of neurology and or neurocritical care since 2008. She started here in Milwaukee at Freighter's, has worked with the Joint Commission, has worked at Stanford in California, and we're lucky to have her back here with us at St. Luke's for the past 4 years. So the format for today is going to be two parts. The first part is going to be a presentation. And I'll ask you guys to stay muted for that first half. And then the second part will be a discussion. So Amy, thank you for being here with us. And I will hand the mic over to you.
Thank you. Thank you, Dr. Mobazelak, for inviting me to be a part of your Friday Chalk Talk. This is pretty exciting. But we kind of got hooked up together after we had a kind of a challenging stroke case several months ago. And I recall that very clearly, but it was a difficult decision for an older gentleman that had a pretty big stroke. And I think the family was really struggling with the patient ended up having some pretty significant dysphagia and really struggled with making that decision to proceed with artificial nutrition and putting a peg tube in, and what's the right thing to do, and is he going to improve or not, all the unknowns sometimes with stroke. So Dr. Mobazelak asked to kind of lead a discussion about dysphagia and how the different tools that our team uses to kind of predict what if there's early indicators and what later indicators are of dysphagia. So just a quick little overview going through my slides. So dysphagia really implicates negative consequences in clinical and functional outcomes, as well as hospitalization, length of stay, with a high risk of aspiration pneumonia, dehydration, malnutrition, and increased mortality rate. When we look at prevalence in dysphagia after strokes, it's really, if you go through the literature, there's really a wide range. It's estimated up to 33 to 73% of stroke patients have dysphagia at some point through their stroke trajectory. And really, this has a lot to do with how when we're assessing aphasia or dysphagia, how early on, and then the kind of clinical or the instruments that we use. Just at St. Luke's and all stroke centers, the guidelines tell us that we have to assess dysphagia in all stroke patients. So, and how it usually works is it's that first dysphagia needs to be assessed before that first PO intake. So here at St. Luke's, our stroke nurses are assessing right away in the ER, right when the stroke patient comes in. And it's, it's a multi-tiered kind of process. We start with our first clinical evaluation with the water swallow test. And if that, the patient doesn't pass there, if they may meet any triggers, for in any sort of facial weakness, any sort of dysarthria, they automatically are failing that initial screen, and then they're moving on to the next tier, which is the speech therapist doing their more formal evaluations. So that's why this percentage of 33 to 73% is really big, because it's kind of encompassing all the different assessment instruments that we use to assess dysphagia. But that said, most stroke patients, their dysphagia will improve or resolve within 2 weeks. However, it's estimated that about 10% of stroke patients will go on to have more of a long lasting dysphagia, more permanent problem. So what the guidelines tell us, and what we pretty much a rule of thumb too that we follow here, that enteral tube feeding with an NG, if oral intake is unlikely to recover within 7 days, and then if we think that it's unlikely to recover within 30 days, to start thinking about a PEG tube. So that said, how can we as providers better predict short-term and long-term dysphagia in stroke patients? So that's kind of the question that I want to pose today. And we'll kind of go through early indicators to start and then kind of later indicators. So with our earliest indicators, kind of when our stroke patients first come through, our emergency department doors, some of the earliest kind of characteristics are age. What is the age of our stroke patient? We're specifically kind of when we're looking at stroke, so the cutoff is kind of age around 75 is when we start to have our more mature stroke patient. What is their pre-morbid status? So what is their baseline function pre-stroke? And then looking at what are all their comorbidities, and the big ones with stroke that have, are more associated with having this more severe dysphagia are going to be like your diabetics, hypertensives, and then they also lump AFib into this as well, because a lot of times patients with AFib are at high risk of having the bigger embolic strokes or showering, having multiple strokes all over. So they put AFib as one of the key, comorbid conditions. I was looking that there was some discussion about gender and maybe females being more prone to dysphagia, but I couldn't really find any good evidence to support that. So those are just some early patient characteristics. I think perhaps lesion location and size of the location is probably one of the biggest early indicators for us for dysphagia. I think when we think about patients coming in and already showing signs that they're having a hard time supporting, their airway or managing their secretions, we're thinking that they're probably having a brainstem stroke, specifically the medulla, given that that is known as our stroke or our swallow center. That's where, our 9th and 10th cranial nerves pass through, so that if we're seeing that and we're suspecting, we're localizing right off the bat that this patient's probably having a brainstem stroke, we're already thinking early on that this patient's probably we're going to anticipate that they're going to have some swallowing problems. And then not just, brainstem, even having large frontal lobe lesions, any sort of, cortical lesion that's going to impair, cause contralateral impairment of the face, the lip, the tongue, any sort of impaired motor control. We're thinking that they're probably definitely going to have, some degree of swallowing difficulty. And then as far as left versus right hemispheric strokes, there is research out there that says that left hemispheric strokes are can cause oral stage dysfunction versus right can cause pharyngeal dysfunction, which in turn leads to aspiration. There's mixed schools of thought about that. Yes and no. I have different feelings about that, but mostly I think the biggest takeaway is that the lesion location and the size is really going to play is a really good early prognostic indicator for dysphagia. And then ischemic versus hemorrhagic strokes. It's just a simple fact that hemorrhagic strokes, especially intercerebral hemorrhages that have interventricular extension, these patients are typically present with a more decreased level of consciousness. These are patients that usually spend a longer time in the ICU, sicker, needing a lot, more interventions. They usually have neurosurgery involved. So just, kind of common sense that these patients probably are going to have a longer difficult time swallowing. So moving on, so we've established our infarct, where it is, how big it is, if it's hemorrhage versus ischemic. Next, we look at our severity scales, and the big the gold standard for stroke severity scales is going to be the NIH stroke scale, which I think most people are probably familiar with. And a lot of research has shown that an NIH score of greater than 12 is pretty much going to be synonymous with having some degree of swallowing difficulty. And I think in my experience as a stroke provider, I would tend to agree that those are going to be your larger strokes. So a patient comes in and their NIH is, that 12 or greater, we're kind of thinking this person's probably going to have some difficulty swallowing. And then also level of consciousness. So what's their GCS score? If their GCS is low, that they have some degree of altered mental status, that we're not going to feel very comfortable right away giving them PO intake. And then lastly, and I think really importantly, our acute stroke treatment. So really in the last 10, 15, 20 years, we've really become more advanced with our acute stroke treatments. And so as providers, neurology providers, we look and see, when we do early prognostication by kind of determining how quick is our stroke patient getting to the hospital, how quick are they getting to the ED, how quick are we able to intervene, how are we able to get them TPA right away, are we able to get them to the IR suite and do thrombectomy. So that really plays a big role in early prognosticating. Was our patient able to get acute stroke treatment? Okay. That said, anybody have any questions so far?
Amy, could you talk for just a moment about the timing of that NIHSS? Does it matter whether it's in the first hour, 24 hours, week?
Yep. So when a patient comes to the ER, our initial NIH, we do it within an hour of arriving. So that's going to be our first initial score. Okay. If a patient gets TPA, if they go for intervention, we do a 1 hour post NIH stroke scale. And then we do it again 24 hours later. So that in itself is a really big kind of prognostic indicator. Early prognostic indicator is, so they came in, let's say with an NIH of 18, they went for intervention, they were able to retrieve the clot, restore perfusion, and now our post, our 1 hour post intervention NIH is now 7, which we see a lot. And so that is a really, positive prognostic sign when we see that NIH, improve so greatly, so quick. So then we're pretty optimistic, from a prognostic standpoint after, if we see that. Unfortunately, some patients, they don't all get better like that and improve so quickly. But, when we do see that, and especially in a younger person, that we see that really huge improvement in the NIH, that where we have a positive, prognostic view for them. Okay.
Thank you.
Mm-hmm. So now moving on to more late indicators, and this is usually, to the point, we're a few days, post stroke. This is kind of sometimes when palliative care ends up getting involved. Things aren't, going as well as we would like them. So again, the NIH can also be helpful as a late indicator. So, we've done our initial NIH, right after any sort of intervention. We've done our 24 hours, and it hasn't really changed or improved much. We look at it again, what is it several days out? Has it really improved at all? And if it hasn't, if it's stayed pretty much the same, we're thinking that we're probably going to need to start thinking, if dysphagia has been persistent, that we're going to need to be making some alternate, means for nutrition. This is when we really get our speech therapists involved, and ask them to help us. And when we start to do, the swallow evaluations, the video fluoroscopy, that's the gold standard. They're doing fees studies a lot more too. And that, as our team really looks to the speech therapist to kind of help us with how is this patient doing? How are they progressing? So the big, I just listed kind of the clinical features and symptoms that we see that are indicators of dysphagia: cough, voice change after swallow, abnormal volitional cough. Do they have a normal gag reflex, dysphonia, and dysarthria? Those are kind of the things that we see in patients. Level of consciousness, of course, is going to play a big part if just using the GCS, if they're persistently less than 12, or even if, with our hemorrhages, if they're in a persistent coma for several days, those kind of all indicate poor swallow outcomes. So, we get to this point that, let's say that we're, in that 3 to 7 days, and we've put an NG tube in, and our patient just isn't progressing like we would like them. They've had their video swallow evals, and our speech therapists are still recommending keeping them NPO. Then we kind of move on to starting making arrangements for the PEG tube. And then I just would like to add that PEG really shouldn't be viewed as an endpoint in the dysphagia rehabilitation, that we try to stress, to patients and family that, speech is still gonna, even though you're getting this this tube in, you're still going to get the therapy. We're still going to, work with you and try, to keep improving your swallow, that this is hopefully just a temporary and that you are going to continue to improve. Okay. So just a few conclusions that I'd like to make, that, post-stroke dysphagia is a common disorder needing the vigilant assessment. Hemorrhagic strokes are more frequently associated with dysphagia than ischemic lesions. And that's, primarily for the fact of how hemorrhagic strokes affect our mental status. Stroke severity and stroke location and lesion size are the main predictors for dysphagia and severity. And then older age, diabetes, hypertension, and AFib are main risk factors for dysphagia occurrence. So that said, I just kind of wanted to open it up now for any questions or discussion. Anybody that had experiences they want to share.
Hi, it's Chandra. I had a question. How are you?
Good. How are you?
I'm good. So I actually had a few, but I'll just kind of start with the first one if anybody else didn't have any. So I am the palliative care provider here in the city in Chicago. And most of ours don't quite even make it. You mentioned in the beginning that, kind of the first week with maybe, temporary measures, and then up to 30 days, then, consider the PEG. But when somehow the discharge disposition kind of pushes that decision on families quicker than 30 days.
Yeah.
And so that's a bit of a challenge.
Yeah. We're definitely always faced with length of stay and pushing the patients out. So yes, I think if we predict that they are likely not going to, improve within 30 days, then we're making those arrangements for the PEG tube, as early on as possible. And, sometimes we know, let's say they have that brainstem stroke, that they're not realistically going to probably improve, even if we give them that 30 days, that we need to start, planning sooner. So, but yes, I do agree that we're faced with the challenges of moving the patients through the system. And
then is there a recommendation for whether or not the PEGs should be reversed at a point? Because I did recently have a patient who was here, who had a previous stroke, gotten a PEG, did well enough that they had reversed it, and then 6 months later was back in my hospital with the family requesting a new PEG. And they were just preferring a new PEG tube as opposed to considering hospice and other options because he had had another stroke. So I'm just wondering what the process is with that, as far as, new strokes versus like repeat dysphagia, the keeping the PEG versus taking the PEG down, like if there's any input from you guys' standpoint on that.
I think it's usually our discussion, when we're involved in family meetings, that we're going to put this PEG tube in, and with a plan to kind of reevaluate down the line, whether it be a couple months, is the patient progressing like we had hoped they would or not. I think it's, usually our goal that it's going to be temporary, but I would say that's just really unfortunate if they had another stroke and then needed to have it replaced. Yeah.
I know, I know that one was a hard one. It was the first one I've ever
Yeah.
had, but it was the first time it ever got me thinking. But I think
Yeah.
that I wrote it down when you said it, that, that I like that you said that the peg is not the end point, that it's kind of a
Mhm.
placeholder or a bridge,
Mhm.
that's going to really help me moving forward with helping them make decisions. So thank
And
Mhm.
I noticed the same thing, Chandra, that it's like, oh, we don't usually say it could be temporary. We're just like, here they need it. And it's also nice when they get better and they can take it out, but they also sometimes decide, I will never do that again. And
Mhm.
but I've had patients come back in and need a second one after a second stroke. And it's
Mhm.
they did it before, they're okay with doing it again.
Mhm. Yeah.
Amy, I've got a question just about your experience with prognostication, because
Mhm.
in the field of palliative care, we know that we struggle with accuracy of prognostication. And in particular, in our cancer patients, we tend to overestimate how much time people have. We tend to be overly optimistic. What's your experience with neurologists and
Yeah.
stroke?
Mhm. I think because in the stroke world, we've, in the past, like I said, 15, 20 years, we've improved stroke morbidity and mortality so much because of these, hyperacute treatments that we that have developed. So I think that we're quick, to have a positive, prognostic outlook if we know that our patient got to the hospital really quick, that we could offer them these treatments right away, that their age, that they're, less than 80 years old. We're giving them these treatments. We're getting them, we're seeing them improve so quick. So I think that we're positive in that regards when we are able to intervene quickly. I think too, we really rely a lot on our MRIs. That we get these pictures and we see that, oh, their stroke burden is not very large. Like, this patient should do well because based on this picture, but that's not always the case. That sometimes we have to look at what, clinically what our patient is actually doing, what they actually look like, and not so much just like treat this picture that we're seeing because it really doesn't look that bad. But yeah, I would probably say that really we base a lot of our, how we think the patient's going to do with, how quick they got to our hospital, and how quick we could intervene, and then what our post imaging looks like.
Thank you.
Mm-hmm.
All right, we're just about at time, Amy. We
Okay.
really appreciate you coming by and spending some time with us and talking about some of the early and late prognostication factors with us.
Thank you. Thank you so much for having me.
Absolutely.
All right.
Have a wonderful
Bye-bye.
Friday.
Have a good weekend,
Thanks,
everyone.
Amy.
Thanks.
Bye-bye.
Take care. Bye-bye.
Bye.